Hello everyone, welcome to today's program, Cost of Technology. Everyone wants it, but can you afford it? Sponsored by Asda's Career Compass and Heartland Dental. I'm Brooke Kachuris, Asda's Membership Development Specialist here at the Central Office in Chicago. Before we begin, note that all attendees are muted so that we don't pick up any background noise during the program. During the presentation, you'll be able to ask questions of the presenters. If you notice a control panel on the right side of your screen, you can type into the question box at any time. At the end, we will answer all questions that we can get to, and we'll provide the contact information for the presenter if you would like to email them directly. Career Compass is a resource to help prepare you for graduation and transition into the first steps in your career path. Asda is excited to work with experts in the field, such as Heartland Dental, to develop new programs and resources for you. Visit Career Compass to explore all it has to offer. I'd like to introduce today's speaker now, Dr. Bob Mongrain. He joined Heartland Dental in 2011. Since then, he has experienced great success as a practicing dentist and is now Director of Clinical Advocacy. Dental education is an ongoing interest for Dr. Mongrain. He has been an adjunct faculty member at Oral Roberts University and currently a faculty member at the University of Oklahoma College of Dentistry. He also lectures and conducts training seminars for dentists around the country and internationally. Please welcome Dr. Bob Mongrain.
Thank you, Brooke, and welcome everybody to this program tonight. This is actually a kind of a first for me, although I've lectured all over the place and done all sorts of things. I haven't done a lot of webinars, so we did practice a little bit, so hopefully it'll be very useful for you. I really like to interact with the audience, and so I appreciate all of your questions and comments as we go along. The title of the program, Cost of Technology. Everybody wants it, but can you afford it? You know, being a dentist for a long time and having worked in a lot of different environments, you're going to learn a little bit and see some of the errors I made. But first, I want to talk just a little bit about me and my family. That's myself and my wife of 39 years there on the left, and our kids and son-in-law, soon to have a second son-in-law, and there's our new little grandson out on Cape Cod, little Charlie. The kids actually live in Austin, and we live in Tulsa, Oklahoma. I grew up in Massachusetts near the Cape, and my parents live there now. Beautiful place in the summertime. I'm not sure I really want to spend too much time there in the winter. And then kind of through life, I went south to escape the snow, and then public health brought me out to Oklahoma. That was 39 years ago. And I've practiced in all sorts of environments. This is our office currently, 10 chairs, 2 doctors, about 4,500 square feet. I had a practice in the mall. I've had 2 partnerships, doctors working for me, working solo, and then the last 7.5 years at Heartland. And Heartland Dental has been the best part of my career. I did public health as well at the beginning, as I mentioned earlier. Such a great opportunity. I've had the best time these last 7.5 years, and really looking forward to more. So here's my Florida picture of my Florida diploma. It's only a license to learn. Good friend of mine, Wayne Laux, who's retired now, he was my territory sales manager for a number of different dental companies. He said, you know, Bob, you're more fun to do business with now that you don't have all the answers. And I guess that's the thing I really want you to understand, is that when you go out those doors, and whatever time it is for you, and I'm not sure where all of you are in your career in education, but it's just a license to learn. Everything changes so much. So today's objectives, we're going to talk a little bit about the present and then the future. And the present has a way of being in the past. I'll show you a little bit of that. Determine what technologies, how to determine what technologies to invest in, and then a little bit about how we approach it here in Heartland. So, you know, the main thing that you need to understand is it's a big subject. And this is a slide I've used for years, and it's like, you know what, we're just going to take a bite out of the watermelon tonight. There's so much more that you can learn, but just want you to know that there are lots of opportunities out there and lots of things. For a lot of people, this is the present, and maybe some of you have seen some of this stuff in dental school. You know, there's amalgam. That's a gold bridge I did years ago, and then the good old PFM using an impression. Certainly impression material works. But the future, how did I get from, in 1979, any kind of filling you wanted, you could have as long as it was silver, to where we are today? It starts with this. I was always searching for ways to make my patient outcomes better. I want you to be thinking about that. I want you to, all through this presentation, all through this program, what have you learned? What are you learning? And what do you see some of the gaps are? Because things are constantly changing. So what should I be looking for? Patient outcomes. When I do treatment, do I get the results I'm looking for? Do I solve the problem? As you go through your career, you're going to be experiencing things like changes in disease and health. I call it Red Bull and Starbucks disease. The amount of high fructose corn syrup is just growing exponentially, and the decay that comes from that has totally changed the environment since I was a dental student, and with the research. And then the third part, or the third component between those two, is modern pharmacology. 200 of the top 250 medications that are prescribed today have dry mouth as a side effect. Drug-induced xerostomia is rampant everywhere. And then finally, consumer demand. I just saw somebody today as a new patient, and he'd just been to Smile Direct Club to learn about his, you know, how he could make his teeth better. And we did a scan and talked a little bit about just more than the social six. But consumers, they want what they want. And if there are people that are willing to give them that, and we have to be prepared for that. We have to be ready to change. So the next step, once you identify some area in your practice that you need to change, and you identify a technology that you want to investigate, the next step is to decide, is this something that is worth adopting? And these are some of the questions. I'm not going to read them all to you because you have them right there on your screen, but I just want you to think about that. In other words, don't do what I did over the years, and I'll show you an example towards the end. Don't just buy something because you think it's really cool. I think one of the things that really is important is at the very bottom. You know, in the United States today, we operate primarily on a hygiene-driven model, and that means patients expect to come in, get their teeth cleaned, see the dentist, you know, hey doc, how are my teeth today? And heavily invested in the PPO environment. And that's the environment we work in. You have to be able to work in a way, whether if you have a niche practice, maybe not, but you have to be able to work within the economic environment that works for your patients. Doesn't mean you shouldn't make investments, doesn't mean you can't change things. You can. It is possible, but you have to be thinking about that. The next area here is the process. So you determine the need, then you research vendors and reviews, evaluate your return on investment, and then you decide how you're going to move forward and choose a vendor. So this is very important. So now that you've decided what you're going to do, then you get narrowing it down further, step by step, narrowing it down. So, okay, I'm going to buy a new scanner. I'm going to jump into scanning. What brand or model gives the best results? Is the manufacturer local, or do they have local representation? Is the training process something myself and my team can adapt to? And then the most important part that you really need to be considering is, what's your action plan? That maybe isn't the last thing. This maybe should be the first thing, but you need to have a plan for adoption. Change management is actually something that people get degrees in. It's difficult to change. So it's so important when you do make any change, whether it's a different composite, a different endodontic system, a different technology, those are all technologies. How you adapt and adopt is key. It's so easy, and I've seen this in offices where people, they get a new technology, they make a pretty significant investment in it, they hit the first road bump, because there will be road bumps, and then they just push it in the corner and some doctors making big payments on this technology but not using it. Do not let yourself be that person. So let me share a little bit about our process at Heartland. And I mentioned it earlier. So Dr. Hodge and I joined Heartland 7.5 years ago. And my only regret is I wish I could have done it sooner. It's been the best 7.5 years of my career. And there's a lot of reasons why. The most important one is just all the support that I have. And I actually kind of evolved into being part of that support, in part due to the passion that I have that you saw earlier in my, in the introduction, working with manufacturers, always looking for something different and better, how to make the world a better place. And, Heartland has really given me a huge opportunity there. Because of that, I've grown from step to step to step. And has been the best part of my career. I don't want to overdo the excitement, but it's pretty good. But then I enjoyed private practice when that was what I was doing, and it was great then. And now we're moving on to the next level. So 5 years ago, being a person who asks questions and looks around, I'm like, there's a lot of scanners out there. We really don't have a strategy, but I know that I've been scanning since 1998, my first CEREC. I know that this is a technology we should be looking at. And I just would talk to people. And we did start to look at it. And then I would do initial evaluations and testing and then say, this one is a good one. So let's do a bigger test. And what in our protocol or format, we'll do a multi-month test in at least 4 offices with several clinicians. And we did that with 3 different systems, not all simultaneously, but we kind of worked our way through. And we identified 2 top systems, the Trios and the Itero Element. We then we did a very limited launch 3 years ago in 30 offices, and we just needed more data. I mean, you really don't know until you have thousands of instances. So we get thousands of cases. And then, one of the people, we're really big on Invisalign, and one of the vendors, namely Align, said, we're going to sue that other company, and through this various circumstances, we can no longer submit Invisalign cases to Trios. So although I do have a Trios system in my office, we decided that at this time, Itero would be the way to go. And last year we did a bigger test, and it's a $1 million test because we purchased 200 systems in 2017, gradually got them out, learned by each round. We kept learning and changing and growing. And then this year, we prepared to do a full launch, and that's our goal, is to achieve 90% of our offices to have at least 1 scanner. By the end of November, we will have done that. Actually, early November, we will have done that. We will have 700 additional scanners purchased this year to add to the 230 that we already had. Now, we're not done, and we're still learning things, and we're still growing, but in 2019, we're going to continue to develop our processes. We've got a lot of work to do there because nobody's really done this at scale before. And then we're always looking, because there's always something new. It's never static. And then we have the opportunity, because we are such a large customer, to participate with our industry partners and really influence and guide the development processes. And that's been really gratifying to have that kind of reach and scope and be able to provide for doctors like me really great technologies. So these are some of the things that we're going to discuss briefly tonight. And looking at that watermelon, we're really, each of these, some of these I've lectured on for a whole half a day on. Others, there's a lot more that we could talk about. So we're going to kind of skim over. I don't think anybody, when they're thinking about practicing, is thinking about putting in a dark room and using film anymore. Digital imaging, at Heartland, we're using the Carestream system as our vendor. That we actually test multiple vendors, and we continue to work, and there's a lot of reasons why. I think there are a lot of good choices out there with digital radiography when you're talking about pano and then the sensors. I've been teaching and lecturing on digital X-ray since the early 90s when it was brand new, and it's interesting that the sensors have not really gotten a lot smaller. I think with the CMOS, CCD technology, they're about as small as they're going to get. Resolution is higher, ease of use is simpler, there's more software tools, but this is this is really state of the art, and I'm sure that many, if not all of your dental schools are utilizing this. I know that University of Oklahoma switched over about 5 years ago to the CareStream system. Now, this is another area, technology, restorative materials. There's major investments being made in advancements in restorative materials, and there's a gradual evolution and there's a gradual adoption of these materials. Here at Heartland, we've done a lot of testing, and I personally really enjoy working with the universal adhesives. I've done a lot of study on them. I actually get to talk to the people that make these things. And one of our current favorites, my current favorites we're using in our office is the Scotchbond Universal. And then another one is Dentsply Select, Primabond Select. And that also, I like them both for different reasons. But this is really high technology because it allows you to reduce your cost by only having one bottle. And yes, some people have they're not sure about doing all in one, but the research has been good on it, and my clinical results have been excellent. Nearly no sensitivity. I typically am using either partial etch at the middle or total etch at the bottom. And what I'm doing right now is kind of a hybrid. I'll etch the enamel and then put some on the dentin, no more than 15 seconds. If you read the directions, doctors, read the directions and be very careful. Make sure that you're very careful with the materials and that they're not exposed. They get closed up right away. If you're doing a bottle or if you're doing single units, make sure you don't use any expired material. This stuff is a little bit sensitive to storage, a lot more than some of the other materials. Then the other big thing, and I've been using SDR since actually before it came out on the market. It's not the only bulk fill material. It's a different one. It's a stress reducing bulk fill material. In this day of PPOs and efficiency, and our patients, they don't really want to pay us by the hour. I just had a crown done a few months ago, and you know what? I was thinking, I felt bad sometimes when I would go really fast on a procedure that was very costly. But I was thinking, as Dr. Sprague was doing my crown prep, it's like, you know what? If I could pay him money to go faster, I would. So, our patients want to get out of the chair. We want to be efficient. So bulk fill materials, Paradigm bulk fill is another one that I've used and like really well. These allow us to go faster, which is more efficient, and faster can be better if you're talking about stress reducing, if you have the right armamentarium and you use the right indications. So I'm not against any of the other materials. I've been using composites for many, many years, but efficiency and time is really important to me. Now, if you're going to do bulk fill materials, you have to make sure that you have the right curing light. And curing light technology has come a long way. And this is my favorite, and it happens to be one of our preferred products at Heartland. We get that from Ultradent. It's nearly indestructible. Durability is down there. Everything drops. And so you can drop this thing. I wouldn't drop it too many times, but it's fully encased. There's other really great lights out there. You can spend up to $2,000 on a curing light. And the key is right here on the screen. The key things that you should be considering. And real life depth of cure. So basically, if they tell me I can do it in 3 seconds or 5 seconds, I am doubling that. Because when you're doing it in a test environment, you can't reproduce those ideal conditions in the mouth. But 10 seconds, it seems like forever when you're trying to move on to the next part, but it really is important. This light is very cost effective. Jumping back up to the top, the LED technology. LEDs are single wavelength technologies, so you have to make sure that your light has at least 2, and some have multiple wavelength LEDs in it, based upon the curing material, the initiator, the photo initiator that's in the material that you're using. So, if I didn't adopt new technology, the kind of materials, the composites I was using, the curing lights I was using 20 years ago, it's a constant change. So I consider this to be high tech compared to what I was doing then. And here's endodontics. And I just checked, and some of you may be already exposed or being ready to be exposed to the Wave 1 system from Dentsply, developed right here in Tulsa, Oklahoma, where I live. I saw the founder of the company last week at the county dental meeting. And this is, I just threw this in here. I actually did another endo this afternoon. This is a single rooted premolar, and you go, yeah, okay, big deal. That's an x-ray of post-op of what I did today. This afternoon, I had a patient come in on an emergency, and we did a 4-rooted molar. Didn't get time to, we finished about 5:15, so I didn't get time to get the radiograph, the post-op. You see a little bit of a spritz of sealer out the apex, but that is a solid fill. Single, I used that primary, single instrument. You know, there's a series of steps that you go through. Irrigation, cleansing is so important, but this is so simple and so predictable. I've used over a dozen different endodontic systems over the last 39 years, starting with lateral condensation. And I'll tell you, I'm just enthusiastic about this. We've had a lot of success. We have a lot of doctors at Heartland that say they really enjoy endo more than they used to using the system, which brings me to what is a general dentist? You know, that's something that we all have to keep in mind. At some dental schools, there's a lot of great dental schools out there, and I'm so excited that you all are in dental school or pursuing that or even out. But you know, there's some of the programs have specialty, and you have to, you know, residents are doing things. Get all the endo that you can. I mean, say yes to any endo that you can. A general dentist today, the expectation from your patients is that you're going to do their fillings and you're going to do their crowns, but you're also going to take out teeth and do some surgical extractions. You don't have to do thirds and fully bony impaction or anything like that. People need to be asleep for that. You can if you want to get the education, but that's bread and butter dentistry. Endodontics, key thing. You've got to get good at endodontics. There's a shortage of endodontists in the United States. When a patient comes into your office and they are in pain, they need you to get them out of pain. And that doesn't mean writing a prescription for narcotics. That means doing treatment. And so it's so important that endodontics be a confident part of your armamentarium, something that you're willing to do. I mean, you know, obviously there are some cases and retreats, but it's really important that be a part of what you do and your expectations. So implants, I'm going to talk about that here in a little bit. That is becoming part of the GP practice. Another high tech that's been around for a while, but is solid, and it should be a part, I think it should be a part of most general offices, is the soft tissue laser, the Diode Soft Tissue laser. We've been using the Cyrolase from Dentsply Sirona for the last several years, and it's obvious, cutting tissue is obvious, but there's also biostimulation. We use it a lot in periodontal therapy, along with Reston, doing everything we can to keep the bad bugs out of that pocket. And the laser has a biostimulation effect. It also has a disinfection. There's research that shows how bacteria can invade the tissue, and the soft tissue laser, when used properly in a periodontal mode, will actually kill those bacteria and reduce the bioload in the pocket. And that's the key, because it's the reaction of the pathogenic bacteria, the body's reaction to those, that causes the tissue loss. So this is another thing you should look really hard at. The direct ROI is probably a little bit harder to calculate on this, except for the ability to provide better treatment for your patients. We do charge a fee for the soft tissue laser when we're doing periodontal therapy. Oral cancer screenings. You all are, those of you that are traditional students, that is, you know, marching through your education, you're in the generation that has to deal with the HPV epidemic. When I went to dental school, nobody told me that I was going to be talking to my dental patients about their sexual activities and how they define sex. And honestly, I don't really. But the fact of the matter is that there's a massive latent epidemic of oral cancer coming, and that's due to the HPV prevalence in the United States. Until the vaccines become more common, and there's millions of people that have been exposed. And we know from the research that's coming out that there is an increase in oral cancer in the United States, and it's not all about alcohol and tobacco anymore. It's about virus, people who are carriers. And so it's really, really important that we do the screenings. That Heartland really brought me to this. And one of the great things that has happened to me is that I've over the last 7.5 years, I do so many of the things that I know I should have been doing, but I hadn't gotten around to, because I have people that support me and encourage me and say, why not? Why couldn't we do that? And this is important. Early detection, we know from the research also that the only key to helping people avoid this, losing their life to this, and I have had patients that have lost their life to oral cancer. I have some patients who have been horribly misfigured due to oral cancer, and it's a terrible thing to see. And so if we can catch it a little bit earlier, the good news is I've also caught a couple lesions that have been removed and had the opportunity to help save someone's life. So now my favorite subject, intraoral scanners. Oh my, you can see that's on the left there is only half of the scanners I've ever worked with. Obviously, a lot of those are obsolete. Here's the craziness of scanners if you really get into stuff. In the center there, this is about 7 or 8 years ago, I think. It's an early E4D system, and we were doing a direct restoration, milling in the office, and then I wanted a zirconia high strength restoration. So at that time, I had to pick up another scanner and do the other tooth with the earlier version of the Itero. That's a 2.9. And over here on the right, there's not a super pretty picture, but these are the 2 scanners that we're mostly using today. We'll always be testing new ones. There'll always be improvements. And but the thing is that they're really good now. And so it's kind of like computers. Well, I'm going to wait till next year to get when the new iPhone comes out. But scanners, it's the time for scanners. So what we're working with a lot at Heartland here is the Itero Element, and now it's the Element 2, just a mild improvement over the Element. And it's everybody talks about the scanner, and it is about the scanner, but actually there's several different systems now that are accurate enough. We don't need any more accuracy. They're quick. We don't need a huge amount of speed anymore. Anything under 5 minutes, it works really well. Most scans can be done under 3. It's really about what can you do with that scan after you've gotten it. And so I call it the digital platform. This happens to be the landing page for the Itero. This is myitero.com. And there's a variety of things that we can do, and that's continuing to grow. So visualization, our patients can't see or feel most of the problems that we take care of, that we need to take care of for them. Our patients come to see us when they're not in pain and they don't know that there's anything wrong. We get to tell them that their mouth looks like this and it's just a disaster. Well, it's really hard for people to accept that. This allows you to co-diagnose. You can see with your patient, they see what you see in high definition, 3D. You can manipulate the models. It makes a huge difference. You can tell your patients about their bite and their occlusion, and that most people do have some malocclusion. Now that we're keeping teeth for a lifetime, it's really important that the teeth function and they're in the proper position. And so in my role, I do that a lot with clear aligner therapy, but this allows them to see where the teeth are contacting. That's those red marks, and where they're contacting heavily, and the deep bite. And the deep bite is one of the biggest problems that I see as far as lifetime of dentistry. Timelapse, we're still getting into this. It's a new feature that we just got last year. So obviously time has to lapse in order for it to work. And we've done a couple of them, but there hasn't been a lot of change yet. But the idea is you have 2 different scans from 2 different time periods, and the software compares them. And look at the legend over there. You may not have experienced this yet, but my patients come in, I talk to them about the wear on their teeth, and they come back at 6 months or a year later and say, so doc, how much have they worn? And I go, 14 microns, exactly. And, you know, I have no idea. I mean, I haven't seen you in 6 months. I don't remember what your teeth looked like. Well, now I have the ability with this system and with the Trios to compare one scan to another in a very highly accurate way. Periodontally, loss of bone, abfractions, excuse me, not loss of bone, abfractions, loss of tooth structure. It's going to be incredibly powerful. We're still learning about that. And then simulating outcomes. Right now, we're working a lot of outcome simulator for Invisalign. This is part of the Itero system. There are also outcome simulators available for aesthetic cases, and it's all computer driven. So you have, it happens in about 30 seconds. And it's really about helping the patient to see what could be. What I tell dental students, and one of the things I've struggled with the most in my career, is my ability, commitment, my willingness comfortable to tell people things that they don't want to hear. Everybody wants to come in and say, yeah, everything looks great, you don't need to do anything. The most important thing that we do as dentists, well, there's many important things, but one of them is to help our patients move forward or do the things they don't want to do, but they ought to. And if there's anything that you focus on, there's many things you'll focus on during your education, you've got to deal with the fact that you know that there's important things, and if you believe in what you're doing and what you've learned, then it's part of your professional obligation to help people make the best choice. And these are all tools. You know, the great thing about this is we have so many tools now, and we can help people understand the why, and then that helps them to move forward, to make the commitment. And then gosh, we love Invisalign at Heartland. I love Invisalign. Dr. Hodge and I went to the very first series of programs that they did for GP dentists when Invisalign was young. It's many years ago. We've got over 1,400 cases in our database, and these are not my cases, because just as a matter of time, I just went and grabbed a couple. Don't let anybody tell you that Invisalign doesn't work. Don't let anybody tell you that Invisalign and clear aligner therapy can't move teeth. It can, and it can't do everything, but we're over the 80 to 90%. I have treated all sorts of cases. I have treated all ages from about 11 on up to 74. Extraction, not by extraction, but single incisor extractions, a lot of different things. So it's an incredibly powerful therapy, an incredibly powerful technology that you really want to understand and make your own decision on it. There are other systems out there. Of course, I mentioned Smile Direct Club. There are minor tooth movement systems. Now that some patents had expired, a lot of different companies are going to be coming out with other therapies, other versions of this. And all I have to say is that, and they're probably very good and they're still developing, but Invisalign has a head start. They've done 5 million cases. They really know what they do, and it's a very solid system. Implants. So I mentioned briefly, implants, I believe, are part of the GP practice now. It's the single, the bridge replacement therapy. We're not doing bridges as often. That's an uncommon thing for me now. 1 or 2 implants is the key. We should all be placing implants. Now, of course, there are cases that are much more complex. Some of the anterior cases, although I've done some anterior cases, soft tissue is a big challenge there. But you need to learn how to take out a tooth. You need to be comfortable with sectioning teeth, and then you need to get comfortable with placing implants where you have bone and where you have adequate structures. And then surgical guides, and we're going to talk a little bit about that in a bit, but just everyday implant placement is an important thing for all of us as GPs to be doing, those that are going to be practicing general dentistry. So that's a little bit about just a few of the many technologies that I call advanced technologies, but are actually out and in the market. But these are technologies that are coming soon, and actually the only one of these that's not actually in widespread use is 3D printing. But I put them down here because the economics and the systems are still maturing for some of these. And so there might not be something that everybody is going to be doing right away. Genetic testing, I've been working with oral DNA for a number of years. I don't use it often. And why is that? I mentioned earlier that the economics and that these tests are amazing. One I use the most is my MyPeriopath. The other one that I've used is the MyPerio ID, which is a genetic testing for predisposition. You know, the reactivity. We can tell patients how reactive they're going to be to the oral pathogenic bacteria. MyPeriopath is basically DNA identification of the pathogens so that you can have a rational, scientific knowledge of what antibiotics you might need to use. The challenge here is that these tests run from $199 to several $100, some more complete ones. And you know, that's your cost. So you have to have certain patients. You're not going to use them all the time. You need to understand the why and the when of each of these tests, but it is incredible. Costs will be hopefully coming down as things develop. The CBCT becoming much more common, really almost becoming like the panoramic x-ray of 30, 35 years ago when it was a brand new technology. The challenge is that, you know, the cheapest systems out there now are in the 60s, high 60s, and that's fairly new. And the full systems are in the 80s to $140,000. That's a significant investment. And so you have to have a fairly large practice, or a practice where you're doing some surgery, doing endodontics, implantology. You have to be able to use it. And so that's why I put it in an emerging technology. This shows a implant planning software, which I'm sure you've seen, where you have the CBCT, and then down right below that by the reconstructed jaw is the digital scan, and it's all incorporated, and you can design the entire case from the crown all the way back. Actually, in some cases, people are fabricating temporaries before the implant's placed. I haven't been doing that yet. And the most fun of all is getting the surgical guide. And that just makes it easier. If you're, you know, surgeons say, oh, I only need a surgical guide for really difficult cases or big cases. You know, if you're not big into surgery, it's kind of nice to know that all you have to do is you know exactly where that implant's going to go. You can plan it with greater confidence. You can place it with greater confidence. And it just takes a little bit less gut lining for us non-surgeons. Now, I say emerging again because it's just now coming into its own, and you would want to consider a lot of these other technologies before you really got into this, particularly relatively new. This is exciting. This is in-office 3D printing. I mean, everybody's talking about 3D printing today. In dentistry, this is the Form Lab, and we're following it. I actually, you know, have regular conversations with the and other companies. We meet with some of our vendor partners who are building software for this, because this is just an output device. You have to have software to go with it. And the other reason that it's not widespread yet is because we have a shortage of FDA approved materials to work with. We can't directly print like aligners. We can't print clear aligners directly. We have to print a model and make a suck down. We can make occlusal guards. We can make some temporaries. And there are doctors who are doing that in their practice. We can print surgical guides. It's just one of those things that you have to kind of pivot everything around to that. But we're watching, and I promise you that we're very interested and very excited about this, and looking forward to a time where we can actually incorporate this into our offices with the CBCTs, maybe hub and spoke, and making that efficient. You know, again, it has to be efficient, it has to be effective, and it has to have a return on investment. You know, that building that I showed at the beginning of the program, that Dr. Hodge and I invested, we built that before we joined Heartland. That building's about 15 years old now. And actually, I'm sitting upstairs in that building here, and we have a second floor. And we spent close to, between equipment and everything else, close to $2 million. And so you want to make sure that you do the right thing. And this is an example. I wish I'd taken a picture, but this is the dumpster behind our office, right behind that building that you saw. On the left is a Hoya Conbio VersaWave laser. It's a hard tissue laser. You know, that was the big thing. I paid $42,000 for it. That was a discount. That was a $20,000 discount because I was going to become a KOL for them. And I did some really cool things with it. I did quite a few of the things you hear about, but you know, it just never, I was never able really to monetize it. And then the company kind of withdrew from the dental market here in the United States. They haven't manufactured them or sold them here in years and years, and it was sitting in the corner, getting in the way. And in February of this year, Dr. Sprague and I took that $42,000 laser and we opened that side door and we hoisted that into the dumpster. And I hope that maybe something that you've heard tonight will help you to keep from buying a $42,000 laser that you have to put in the dumpster and say goodbye to that money. So that's my story tonight, and I hope that you have enjoyed it. And I think we're going to go to questions here, Brooke, and you're going to take back control. Is that correct?
That's right. Okay. Thank you so much, Dr. Mongrain. So we're going to move to questions right now. Please make sure that you put any questions that you might have in the question box, and we'll get through as many of them as we can right now. First question, when I become an associate, is it appropriate to work with the lead doctor to give suggestions on what technology improvements that offices can use, or is it overstepping boundaries?
You know, that's a really big subject. Dr. Hodge and I practiced together for 25 years, and partnership and relationship was the key. And we each had our strengths. Dr. Hodge, it was kind of a joke because I was talking all about hardware, but you know, he did hardware. In other words, he spent late nights on the internet figuring out where we should buy our computers. I'm so glad I don't have to do that anymore. And I would do software, more about the team and that kind of thing. So I think part of it is really developing the partnership with that senior doctor and being a good student and hearing and listening. Remember, I was the guy who had all the answers when I got out of dental school. And it's okay to kind of watch and wait. And then there will be a time, if that's a strong partnership and it's one that's going to be lasting, there will be a time. And a great senior doctor will want to hear what you think. So I think that's also a part of, you know, when you're looking for a situation to work in, is it one where it's a partnership? And in other words, partnerships are earned and trust is earned, but you know, that it's a two-way street, that there's an idea that, you know what, even as a young doctor, you do have something to offer because you've been exposed to a lot of things in your education.
Another question, what about procedures that insurance doesn't cover?
Well, that's part of the story. You know, there's some things that I do that insurance doesn't cover, and that's part of your practice management. That's part of your leadership. It's about diagnosing what the patient needs. You know, one of the sayings that we have is, it's my job to let you know what your options are, and it's your job, I'm telling this to the patient, it's your job to decide what you're going to do. So for some of my patients, you know, we try to work with the insurance. I try to go with that, but I also know that there are times, like particularly like oral DNA, it's like, hey, you know, we've done everything we know to do and things are not working. We need to go to the next step. Are you interested in going there? And some people say yes, and some people say no. And so it's always about helping people to understand and helping them to make a decision. There will be things that you do that aren't covered by insurance. You should be doing things that aren't covered by insurance. I think one of the things I'm thinking about is like something like oral DNA. You know, that's easy. It's not too expensive. Oral cancer screening, not too expensive to get started in. But maybe a CBCT 3D X-ray that you spend $100 grand on. There are ways to get reimbursed for it, but you got to work at it. And so you have to be careful about which investments. You know, a hard tissue laser, is the ROI really there for some of those?
Okay, when should I do total etch adhesive?
Always in the anterior. And I go back and forth between etching only the enamel or putting a little bit of etch on the dentin in the posterior. I can tell you that if I've taken out an old restoration, I will etch the dentin because it's sclerotic. The key is to understand, to time yourself, to carefully rinse, and to have the right amount of moisture. And I actually have a 12-minute segment on getting the right amount, getting all those right. And then the number one thing, if you read the directions, and I've watched the people in the labs do their tests on bond strength, and they scrub. And so you need to have copious amounts of adhesive, and you need to agitate it, and you need to do it for as long as they tell you, and make sure there's plenty of it. And then you need to air dry very carefully to get all of the carrier out. So like for the Scotchbond, it's ethanol. That takes longer to get that dried out. Take that out of there because it's only a carrier. If you leave that behind, if you leave water or ethanol behind, you're going to have sensitivity and weaker bond strength. For the dense ply Primabond, it's oh darn, I just went blank. It's very volatile, just 1 or 2 blasts. But the key is to make sure that you follow each single step. So it's only partially about the etching. It's about meticulous technique, predictable, and making sure your materials are good. I answered more than your question, but you know, that's the longer version of it.
Are scanners as accurate as impressions?
Scanners are more accurate than impressions. So there's research on that. Just so happens that the most accurate scanner on the market is the Trios, but they are actually more accurate than impressions. The industry average for remakes from the lab doing impressions is 7% of the cases. With scanners inside of Heartland and outside of Heartland, it's around 2%. And working with our partner labs, I think we can get that down to under, for scanner issues only, we can get that down under 1%. So they're definitely more accurate.
And how much does a scanner cost?
Depends on the product. Retail will run from, well, the least expensive one, well, it's not as, the True Definition from 3M is in the low 20s. And then it goes from the Itero Element 2 is in about 32. And then you go up there, the Trios is in the high 30s to low 40s. And then the Omnicam from Sirona, Dentsply Sirona is 60 grand.
What are some of the technologies I should plan to have when I first start practice or when I buy one?
Obviously, digital radiography, and of course, you know, digital charts, no paper charts. There aren't that many offices that have paper charts, but you do not want to have paper. You want to transition to paper if you take over a practice. Away from paper if you take over a practice. If you can find a way to do scanning from day one, I would do it. We scan all of our new patients. We do outcome simulations. We do time lapse. So the scanner is so much more than just replacing impression material. You can calculate about a 5-year ROI if you're talking about restorative, return on investment. So it'll pay for itself in 5 years, savings with impression material, reduction in remakes. Where in offices where they're really utilizing the scanner and they're utilizing it in the hygiene room and doing outcome simulations and doing a lot more occlusal therapy, correcting malocclusions, you can cover it in a few months. At Berkshire, I grew up in the Pankey-Dawson area of Florida when they were alive. I've been talking about occlusal guards my entire career and occlusal wear, and I have hundreds of patients that haven't gotten them. We started scanning. We went from 3.4 on average, that's an average occlusal guards a month, to 14 a month between Dr. Sprague and myself in a matter of 6 months after me talking about it for 35 years. So that would be one. The main thing is digital radiography, digital charts, oral cancer screening. Absolutely, most of the technologies that you saw in the first section, I would just start with those. Go to an implant course, for sure.
I've gotten some sensitivity on a few fillings. How can I prevent that?
I kind of answered that question earlier on when we were talking about the etch. What I have found is just meticulous technique. Getting used to a different adhesive. I found the going from Prime and Bond Select to the Scotchbond with the ethanol, I was under drying it, and so I actually had some sensitivity early on with that. Another situation, another time, all of a sudden I started having several cases that were sensitive, and I was like, what is this? And I looked up in the charts, and it turned out that they had been scheduled in room 3. I operate out of several rooms, but 3 and 4 is my primary operative. And I went there and I shook the bottle, and you know what? It was almost empty. And that material was bad, and it was a bad, I don't let them empty the bottle. We're not using single dose yet, unit dose yet. We're all going to be doing that. So every step along the way, the right amount of etch for the right time, the right amount of moisture, just moist, the right amount of agitation with good fresh material. They do not dispense the material or open the container until I'm actually ready to place it. It does not sit out on the counter in the little thing. It just, as soon as I'm ready for it, that's when they dispense it.
At our school, they say lasers don't really do anything special. Is that true?
I disagree with that. I have a book over here on the shelf. There's a book of a compilation of research about light energy that started in 1920s, and it's about 400 pages. I think the real thing is there's two things about that. One is, one, we don't understand what biostimulation does yet. And two, many of the studies that I've reviewed used improper protocols. So there's a range of energy that you need to deliver to the tissue to have the appropriate effect. And if you design a study that doesn't use the right parameters, you'll not get the results. I have here in Tulsa, know 2 periodontists, anti-laser, totally anti-laser. I know 2 other periodontists, the ones that I refer to, that have invested each $60,000 in the millennial laser that will actually grow back bone. So it works. I've seen bone grow. Is it the panacea for everything? No, but lasers work. They have their place. So I think, all or nothing and never and always are the things I try to avoid. But there's definitely a place for lasers in dental practice. And the nice thing about the diodes, and particularly there's dual wave diodes that are coming out now. They're becoming very popular, and those deliver a lot of energy to the tissue without damaging it. And you can purchase them under $8,000. $6,000 to $8,000 can get you into the laser business.
All right, well, that's all the time we have for our questions tonight. Thank you so much. If you're looking for more career-focused education, join us live at the National Leadership Conference in Chicago. Registration is now open. We'd like to thank you for participating in tonight's program. I would also like to thank our speaker, Dr. Bob Mongrain with Heartland Dental, for presenting to us tonight. This program was recorded and it will be posted on ASDA's website and emailed to all participants. Thank you so much for joining us and have a great night.